Hi, my name is Salima and I am a second-year MPH student in the Department of Tropical Medicine and Infectious Diseases. Today, I am here with Dr. Ronald Blanton, professor and chair of this department, to talk about his pathway to public health. Hi, Dr. Blanton.
Hi, Salima. Good to see you.
Good to see you too. So, my first question for you is, how did you discover public health?
Public health is a really broad topic. What do you mean by public health? Usually that's a whole series of things, and so almost every point in your life can point you in a certain direction and lead you in that direction. And for me, it kind of begins with grade school, no less, where I could take Spanish on the weekends for free in Omaha, Nebraska. That's back in the good old days. And continued with language all the way through. And language has been important in my whole career. It's directed me in the direction of looking towards issues that are international. And I think that is one of the keys to how I began to be interested in public health. Obviously, going through medical school training and seeing populations in the United States and abroad ultimately is what stimulated my interest.
So you mentioned a little bit about your start in grade school and with language. From there, how did you get to where you are now?
Long path. After I finished college, I was awarded a grant to study folk medicine on the north coast of Peru. Peru, again, because of Spanish. I might have done it somewhere else, but this kind of directed me and put me in that direction. And the experiences there, dealing with or seeing people and the conditions they have, seeing the diseases that they developed, sent me in the direction of infectious diseases when I went to medical school. I did my medical training at Case Western Reserve University, and then did a residency in Chicago, but came back to Case to do a fellowship in infectious diseases. At that time it was called geographic medicine, what now we might call global health or tropical medicine. And again, my interest remained looking at infectious diseases and looking at the biology of infectious diseases. I was trained in molecular biology there, and that is something that's really laboratory focused, but I had the opportunity to study abroad while I was there, either in Kenya or in Brazil. And given, again, with Spanish, there's a short distance between Portuguese and Spanish. I chose to work in Brazil. And developed a research program looking at a parasite, schistosomiasis mansoni, in Brazil as a fellow. When I came on to the faculty at Case Western as a assistant professor and associate professor, again, I had developed a research program in populations and had a whole lot of experience with populations, but wanted to move at that time into genetics. And to do that, I needed to go back to school. And I went back and got a master's in genetic epidemiology. The first part of epidemiology at that time is that they would give you a list of problems to solve, mathematical problems, both sides of a page of paper. I looked at the first two problems and decided, no, give me the course. So I took the no-credit course for Math for Dummies. And I was amazed at how everything that seemed to fall out of the professor's mouth was relevant. I'm not a person who was in love with mathematics, but this taught me that you actually see more when you give that kind of analysis over reality, that there is a reality that's practically hidden from you when you don't do that kind of analysis in terms of epidemiology. So I had a whole lot of experience in population-based research that now I had tools to apply to that made it a lot more interesting, things that I could reveal about populations that I'd not seen before. And I could use genetics to actually uncover a lot of things, not only about people, but uncover things about pathogens that we work with. Schistosomiasis, I've worked with dengue, I've worked with hepatitis C, I've worked with echinococcus. The places that I've done research are, in addition to Brazil, I did eventually go to Kenya. I did years in Egypt working on schistosomiasis and hepatitis C. And most recently, I've done work in Cote and Senegal, which I have found also to be really interesting and reveal a lot about different aspects of these diseases.
So I have a follow-up question, actually. So with your medical background, how do you find that you kind of interweave that into your public health day to day?
Again, you're asking difficult questions because sometimes I don't see a whole lot of daylight between those things. I think many people who are in public health, sometimes they don't think of them as physicians, but many of the people who are leaders in public health are physicians. And that has always been our interest. Medicine is sometimes criticized because it deals with disease, whereas public health is more involved with disease prevention. But I think that is a concern for physicians as well, one class of physicians. The experience of doing research in public health, actually more than my medicine reflecting on my public health, has reflected back on my practice of medicine. I actually think I practice better medicine now, one in terms of the questions you ask, but in addition, thinking about the application of research to public health, what I find is I have a much more systematic way of analyzing disease problems because of my experience in training in research. One of the things that happened when I was doing my medical training is I was farmed out to a basic science laboratory. And that was extremely useful to me because they have a different way of viewing data as opposed to what you learn in medical school. I think it's a better and more important way of viewing data. But it was important for me to have that training in just basic laboratory science that you can then take and apply things to the field, ask good questions in the field.
And so you talked about your work with schistosoma. So how long have you been working on schistosoma mannsoni, you mentioned?
You're going to think I don't have much imagination because I've been, not exactly since I was a very young boy, but ever since I was my second year as an infectious disease fellow or geographic medicine fellow, I have always at least carried schistosomiasis along as an emphasis on what I do. Like most infectious diseases, it expands into a whole lot of different areas. It expands into economy, sociology, culture, are all involved with the transmission of disease, so all of those things need to be studied. In addition, it kind of bleeds itself into other diseases. The places that I had worked at the time, dengue was a new disease in Brazil, but that's where I was doing schistosomiasis. And at the same time, then I began to do studies on dengue. While I was in the city of Salvador, they were seeing a mysterious disease that no one could really understood what it was. I did not know either, but it turned out to be Zika, was exactly at the time that I was there. So although I worked on schistosomiasis as kind of the continuum, I've had these exposures to other conditions, which I think also has enriched the way I think about disease and public health in general.
So talk a little bit more about schistosomiasis. What is it? What is it caused by?
Some people call it snail fever. In Africa, it's often referred to as bilharzia. It is a disease that is transmitted by water. The parasite penetrates directly through the skin. It can disappear from the surface of the skin in 30 seconds and the full thickness of skin in 30 minutes. It eventually migrates to the heart, and then from the heart to the lungs, and from the lungs to the liver, and one species then goes from the liver into the bladder. The parasite itself is pretty silent in all of these places, the adult worms, but the eggs that they lay stimulate a strong immune response so that you end up having damage to the liver or damage to the kidneys and the bladder caused by this disease.
So you mentioned a lot of your work internationally. Do you see any schistosoma cases here in the U.S. or in New Orleans specifically?
I haven't heard or seen any in New Orleans. In Cleveland, we used to, but they were all immigrants, and they were all immigrants from Puerto Rico. Puerto Rico used to have a large amount of schistosomiasis, well over 10% of the population in the 1940s. But currently there's none. But you still have people who remain infected. The parasite is long lived. And we would see them from time to time. And this was not that long ago in Cleveland, Ohio. But in New Orleans, I haven't seen anyone with schistosomiasis.
So what area of public health are you currently working in and working on?
Sort of three areas at once. As usual, schistosomiasis and the genetics of the parasite, as I've mentioned before. We're also working on the remote sensing, not exactly remote sensing, but the diagnosis of skin diseases by cell phone. And also on antimicrobial resistance in surface waters.
Oh, you mentioned diagnosis by cell phone. Can you talk a little bit more about that?
In Cote d'Ivoire, they actually have a fairly good clinical system. They have small clinics that are distributed within the population with usually a nurse, sometimes a doctor, and a lot of community workers. They take care of malaria and normal childbirth. But they are within 5 to 10 kilometers of anybody in the population can find one of these places. They don't have a lot of sophisticated diagnostic tools at that rate. I think they do a good service on what they do, but they don't have sophisticated diagnostic tools. As with most things, even in the United States, the specialists are all centered in the capital, Abidjan, so that it's difficult to get a diagnosis of skin diseases out in rural areas. Whereas if you can take a picture and send that to the capital, they can begin to make a diagnosis based on the image. And dermatology, more than many other subspecialties, is one that utilizes visual clues to make a diagnosis, to be able to look at things. An image may not adequately represent all that you would see on physical exam, so we can combine that with thermal sensing. We can actually use cameras to see the infrared signature on a lesion to determine how warm it is, and gives you even more information, as well as determine the depth of some lesions. We are trying to combine that with, of course, AI, so that those images can be analyzed quickly by artificial intelligence and then subsequently reviewed by a physician.
Wow, that's very interesting. So if you had to tell a prospective student what tropical medicine is, what would you say?
I would direct them to our website. We have a link that actually has a definition of tropical medicine there, because the question comes up a lot. People wonder, are we sitting on the beach with a cocktail with a little umbrella in it, or do we hack our way through the undergrowth? Tropical medicine is, like public health, a broad series of disciplines that concentrates on diseases that are 35 degrees north or 35 degrees south of the equator. These are the tropics and the subtropics. And all of Louisiana is considered subtropical. So many of the conditions that we see in the tropics, we also see in Louisiana, including this next one, which is we work mainly with low and middle income countries, and those are also centered in that region in the tropics, which also includes Louisiana is the poorest state in the Union, so we have a lot of things in common with these other places that we work. So tropical medicine was initially centered around parasites, because that was the sexiest thing you could work on in the turn of the 19th century, turn of the 20th century, was on the life cycle of parasites, give you Nobel Prizes and things. But it then turned towards the other conditions that exist more in the tropics than in temperate areas, like many viral diseases, like some bacterial diseases that we find in those areas. Notice that you gave our departmental name, Tropical Medicine and Infectious Diseases, just to clarify what aspect of the tropical diseases that we work with. Because tropical medicine could include mental health, it could include cancers, it could include metabolic diseases like diabetes and heart disease. All of these are problems that may have special aspects in the tropics. But infectious diseases is what we in this department focus on.
Thank you so much for your time, Dr. Blanton. I always enjoy talking to you about public health.
Oh, the pleasure was all mine, Salima. Come by anytime.
Of course.